Welcome to the Yale20 on acute cholangitis, where we will discuss how to care for a patient with an acute infection of their biliary tree. My name is Alan Zacco.
And I'm Robert Lamb. Dr. Munraj from the Advanced Endoscopy section of Digestive Diseases here at Yale served as our faculty advisor for this presentation.
This presentation will be broken down into several sections. First, we will discuss the initial bedside assessment of a patient with a suspicion for acute biliary infection. This will include a discussion of how to recognize a patient with suspected acute cholangitis. We will also talk about triage considerations and the general treatment approach for these patients. Proper diagnosis, as in all acute illness, is essential to management strategy. In our second section, we will discuss diagnostic testing and the diagnostic criteria for acute cholangitis based off the International Consensus Guidelines, the 2018 Tokyo Guidelines for Acute Cholangitis. Laboratory testing and imaging findings will be discussed here as well. Grading the severity of disease can be important for triaging considerations and for timing of intervention. We will mention how to grade disease severity in this portion as well. Thirdly, we will discuss hospital management of these patients, including patient stabilization with fluid resuscitation, antimicrobial therapy and choice of agent, and intervention considerations, as these patients will invariably require either advanced endoscopy or interventional radiology consultation to achieve source control for infection management. We will then provide a brief overview of how to organize a detailed write-up for these patients. We will conclude by summarizing our talk and providing quick take-home points for the admitting resident.
Acute cholangitis is a clinical syndrome of jaundice, fever, and right upper quadrant abdominal pain, resulting from obstruction and infection of the biliary tree. The disease was first described in 1877 by Jean-Martin Charcot as hepatic fever. Thus, the combination of right upper quadrant pain, fever, and jaundice later became known as Charcot's triad. Acute cholangitis is an ascending infection of the biliary tree. Biliary obstruction at the level of the common bile duct prevents drainage from the biliary tree and allows for propagation of ascending infection in the biliary system. Biliary obstruction then causes elevated pressures within the biliary tree and allows the microorganisms and endotoxins from ascending infection to enter the systemic circulation and cause a systemic inflammatory response. This mechanism drives the clinical manifestation of acute cholangitis. Pain and jaundice from biliary obstruction and fever from systemic inflammatory response. The most frequent etiologies of acute cholangitis are biliary calculi in up to 70% of cases, benign biliary stricture, post-ERCP instrumentation, and rarely malignancy. Other entities such as Merizi syndrome, which is biliary calculi lodged in the cystic duct, but large enough to also obstruct the common bile duct, also exist. However, they are much less common.
The initial evaluation for a patient with suspected acute cholangitis should occur rapidly at the bedside to determine appropriate resuscitation and triaging. Symptoms which are suspicious for acute biliary infection include fever, chills, abdominal pain, jaundice, and altered mental status. Acute cholangitis can be associated with rapid deterioration due to sepsis, which can lead to multi-organ dysfunction, including circulatory failure, respiratory failure, acute kidney failure, acute liver failure, and acute confusion. Thus, assessing for end organ dysfunction is important for determining the suspected severity of disease and the appropriate triaging of patients. All patients with suspected acute biliary infection should be admitted to the hospital for medical management with parenteral antibiotics and consideration of advanced interventional gastroenterologic or radiological procedures. So it is important to determine the appropriate care setting for each patient. While mild to moderate cases can generally be admitted to a general medical floor or step-down unit, severe cases require closer monitoring in an ICU setting and generally urgent intervention for biliary tree decompression or source control. There will be more on grading severity later in this video.
Vital sign monitoring is a key initial step in assessing whether the case is urgent or not. If the patient is hemodynamically unstable, then it goes without saying that prompt resuscitation efforts should be initiated prior to definitive diagnosis. For acute circulatory failure, fluid resuscitation is provided, generally with 30 milliliters per kilogram of isotonic crystalloid solution. IV antibiotics should be started as soon as possible after drawing for blood cultures, as this has been shown to improve mortality. If the patient is in shock, pressors should be initiated and the patient should be transferred to the ICU. If acute respiratory failure is present, oxygen support may be required. Patients with severely altered consciousness are also likely not appropriate for a general medical floor, and so step-down or ICU may be required. The initial assessment should include a detailed medical history, taking into account the timing of the appearance of symptoms. Assessing the patient's state of consciousness is vital. The evaluation should also include assessment of the presence or absence of a conjunctival jaundice, location and severity of tenderness, and signs of acute abdomen. Murphy's sign, or palpation of the right upper quadrant causing the patient to catch their breath due to pain during deep inhalation, is specific to acute cholangitis and should be assessed in all patients. Of note, elderly and sick patients may present without any pain. Once the patient is stable, further diagnostic studies should be performed in order to determine if the patient has acute cholangitis or not. Finally, patients should be made NPO, as biliary drainage procedures are often required for source control.
Traditionally, acute cholangitis has been diagnosed based on the clinical signs of Charcot's triad: jaundice, fever, and right upper quadrant abdominal pain. This triad has a high specificity, greater than 90% for acute cholangitis. However, the sensitivity is low at 50 to 70%. Thus, with the triad having such a low sensitivity, it has a very limited role in diagnosing acute cholangitis. The International Consensus Guidelines for Acute Cholangitis, the Tokyo 2018 guidelines, have broken down the diagnostic criteria into 3 sections based on Charcot's triad, but with more data required. This has increased the sensitivity to 92%. Systematic review investigated sensitivity of Raynaud's pentad, which was consistently low with an overall value of 4.82%. The specificity of Raynaud's pentad was not studied.
The diagnostic criteria for acute cholangitis was created by an international group who formulated the consensus guidelines known as the Tokyo Guidelines 2018 for acute cholangitis. The criteria is broken down into 3 domains based off of Charcot's triad: systemic inflammation, cholestasis, and imaging findings. You will notice that abdominal pain and tenderness do not have a role in the diagnostic criteria. That is not to say that abdominal pain and/or tenderness is not an important clinical finding. It is and should be assessed in all patients with suspected biliary obstruction. However, when used in a diagnostic criteria, it lends itself to too many false positives for acute cholangitis, since acute cholangitis is also highly correlated with abdominal pain. The false positive rate when abdominal pain was used in the criteria was nearly 40%. However, when abdominal pain was removed from the criteria, the specificity increased from 66% to 77%, and the false positive rate decreased to 5.9%. Suspected cases will have 1 item in the systemic inflammation category and 1 item in the cholestasis or imaging finding categories. Definite cases will have an item in each of the 3 categories.
All patients with suspected biliary tree infection require laboratory testing. Blood tests to be collected in all patients with suspected cholangitis should include the following: complete blood count with white blood cell differential, C-reactive protein, albumin, alkaline phosphatase, gamma-glutamyl transferase, aspartate aminotransferase, alanine aminotransferase, bilirubin, chemistries, lactate, and PT/INR. Blood cultures should also be drawn, especially if high fever is present. Interpreting the data is important for diagnosis. Again, the diagnostic criteria is based on signs of systemic inflammation and cholestasis. Per the diagnostic criteria, systemic inflammation is defined as having fever, leukocytosis, leukopenia, or elevated CRP. Fever is defined as temperatures greater than 38 degrees Celsius. Leukocytosis is present if white blood cell count is greater than 10,000, and leukopenia is present if white blood cell count is less than 4,000. Finally, at Yale, an elevated CRP would be defined as greater than 10, since we use high sensitivity assays here. If any of these are present, then the patient is said to have systemic inflammation. Cholestasis is defined as decreased bile flow, either impaired secretion inside hepatocytes or mechanical obstruction of bile ducts. Cholestasis is reflected by elevated bilirubin, predominantly direct bilirubin, along with elevated alkaline phosphatase. If the total bilirubin is greater than or equal to 2, then the patient is said to have jaundice and signs of cholestasis. To have abnormal liver chemistries based on the diagnostic criteria, each liver chemistry lab should be elevated greater than 1.5 times the upper limit of normal for the lab.
Imaging plays an important role in the diagnosis of acute cholangitis. However, despite advances made in imaging modalities, still, we are not able to directly diagnose acute cholangitis based on imaging findings. Instead, we look for indirect measures that, when combined with clinical and lab evidence, can help diagnose acute cholangitis. These include biliary duct dilation and evidence for an etiology, such as bile duct stones or malignant stenosis. Abdominal ultrasound is generally the first imaging study performed, given its minimal invasiveness, wide availability, convenience, cost-effectiveness, and lack of radiation exposure. Abdominal ultrasound can detect abnormal biliary ductal dilation and its cause, such as biliary duct stones, malignant stenosis of the bile duct. Ultrasound has high specificity for detecting features of acute cholangitis, but low sensitivity. In one meta-analysis, abdominal ultrasound has a sensitivity of 42% and a specificity of 96% for detecting a dilated common bile duct, and a sensitivity of 38% and specificity of 100% for detecting bile duct stones. Of note, ultrasound is a poor choice of imaging for patients of larger body habitus.
Abdominal CT scan has high sensitivity for detecting bile duct dilatation and biliary stones. It is also useful for diagnosing local complications due to acute cholangitis, such as liver abscess. It also has a large amount of radiation associated with it. Oftentimes, people with abdominal pain will get a CT scan in the ED. This would obviate the need for abdominal ultrasound. When abdominal ultrasound and CT scan fail to demonstrate evidence for acute cholangitis, and you are still suspicious for a diagnosis of acute cholangitis, magnetic resonance imaging, and specifically magnetic resonance cholangiopancreatography, can help demonstrate biliary duct dilation, stones, and evidence for an etiology based on its superb sensitivity and specificity.
The most useful imaging test for evaluation of acute cholangitis includes endoscopic ultrasound and MRCP. Endoscopic ultrasound is the most sensitive and specific test and involves an ultrasound transducer attached to an endoscope. It only takes 5 minutes, and upon identification of a stone or obstructive etiology, can be converted to ERCP for intervention. As discussed previously, MRCP is also an excellent option, though is less sensitive for stones less than 6 millimeters and distal stones close to the ampulla. A systematic review and meta-analysis comparing endoscopic ultrasound to ERCP in detecting choledocholithiasis in a head-to-head study involving 5 prospective studies and over 272 patients revealed sensitivity was 97% for EUS as compared to 87% for MRCP.
The differential diagnosis is important to consider and includes other causes of right upper quadrant pain with associated fever. Acute cholecystitis is common but can be distinguished easily from acute cholangitis. Acute cholecystitis should not be associated with a significant elevation in liver chemistries as one would expect with acute cholangitis. Moreover, imaging would not show a dilation of the common bile duct, as the gallstone is generally lodged in a cystic duct in patients with acute cholecystitis. Biliary leaks are complications of bile duct injury, generally after laparoscopic cholecystectomy. This diagnosis should be suspected based on history of recent bile duct manipulation. Acute pancreatitis is distinguished by history and laboratory data with elevations in the serum lipase. Imaging findings would also help differentiate these conditions. Liver abscesses are differentiated from acute cholangitis based on imaging findings. Acute hepatitis should also be considered in patients with right upper quadrant pain, fever, and chills, and would be differentiated from acute cholangitis from a primarily hepatocellular pattern of transaminase elevation.
Severity grading of acute cholangitis can be useful for both disposition purposes and to identify patients that may benefit from early biliary drainage. Mild acute cholangitis is defined as a diagnosis of acute cholangitis that does not meet criteria for moderate or severe disease. Moderate disease is defined as acute cholangitis that is not severe but requires early biliary drainage. Formally, it is defined as having acute cholangitis with any two of the following: an abnormal white count, high fever, older age greater than 75 years, total bilirubin equal to or greater than 5 mg per deciliter, and or hypoalbuminemia less than 0.7 times the lower limit of normal. Severe disease is defined as acute cholangitis with sepsis-induced and organ damage. If any one of the following organ systems is persistently damaged due to acute cholangitis, then the disease is said to be severe: cardiovascular, neurologic, respiratory, renal, hepatic, or hematological dysfunction.
Disease severity scoring is important for disposition and for identifying who may benefit from early or emergent interventions. Patients with mild disease are usually admitted to a regular medical ward. Most patients can be treated with antibiotics and do not require biliary drainage. If a patient does not respond to this initial treatment, however, then biliary drainage should be considered. Patients with moderate disease require early biliary drainage. In fact, we know from observational studies that 30-day mortality is reduced in patients with moderate disease who have early, within 24 hours, ERCP. These patients are often admitted to a regular medical ward or to a step-down unit. Patients with severe disease require ICU-level care. These patients are often unstable and require aggressive resuscitation efforts for stabilization. Often, they require emergent biliary drainage, and endoscopic or percutaneous transhepatic biliary drainage should be performed as soon as possible after stabilization.
The overall treatment approach for patients with acute cholangitis is initially with supportive treatment and hemodynamic stabilization. Again, severity grading can help decide how to triage patients for both hospital disposition and timing of therapeutic intervention. Antimicrobial therapy plays an important role in disease management, given that acute cholangitis represents an infectious process. In most cases, endoscopic or percutaneous biliary drainage is necessary for source control and to prevent recurrent episodes.
Vital sign monitoring and hemodynamic stabilization are the most important initial steps in managing acute cholangitis. Biliary drainage should only take place after the patient is initially stabilized. These initial resuscitation efforts include IV fluid administration, usually with isotonic crystalloid solutions. Lactated ringers is a good initial choice, as data suggests it may be superior to normal saline in critically ill patients. Generally, fluids are administered until the patient's blood pressure normalizes or you reach a total volume of 30 milliliters per kilogram. If initial fluid resuscitation does not stabilize the patient's blood pressure, then they will require circulatory support with vasopressors. Abdominal pain can be treated with opioids. Although there is some concern that opioids can mask the abdominal pain and cause a delay in diagnosis, this fear has not borne out in trials and analgesia is considered safe. Patients with end organ damage may need appropriate organ support. Often these patients will require intensive care unit level of care. Finally, patients should be made NPO when initially presenting to facilitate early or emergent biliary drainage if necessary. Special consideration should be given to patients on anticoagulation. This should usually be held in anticipation of intervention and even reversed if needed. Consultation with cardiology and/or hematology may be necessary.
Antimicrobial therapy is important for improving patient mortality and for allowing for fewer emergent biliary drainage procedures. In one retrospective study, 53% of patients who responded to antimicrobial therapy were provided elective rather than emergent operations. Antimicrobial therapy also limits the systemic inflammatory response and prevents intrahepatic abscess formation. Blood cultures should be obtained prior to antimicrobial therapy so that a causative organism can be identified, and antimicrobial therapy can be tailored to said organism. In the case of acute cholangitis, the rates of positive blood cultures are 21 to 71%. For patients with septic shock, appropriate antimicrobial therapy should likely be administered within 1 hour of diagnosis. For less acutely ill patients, this should occur within 6 hours of diagnosis. The microbiology of acute cholangitis is decently well studied. The most frequently isolated organism seems to be E. coli across all severities. Other commonly associated organisms include Klebsiella, Pseudomonas, and Enterobacter species. Choice of antimicrobial is often dependent on the severity of the disease. In patients with mild disease, ampicillin sulbactam is usually an appropriate empiric regimen unless local resistance of E. coli is greater than 20%. Cephalosporin-based therapy is also appropriate with the addition of metronidazole. For more severe disease, covering Pseudomonas is important. Sozocin or ceftazidime and metronidazole can be effective initial regimens. If a causative organism is identified, then antibiotics can be narrowed based on the resistance pattern of said organism. The duration of antibiotic therapy depends on how quickly source control can be obtained and based on the clinical stability of the patient. Generally, antimicrobial therapy is recommended for a duration of 7 days after source control has been achieved. In patients with bacteremia, this course may need to be extended based on the causative organism.
Consultation with the advanced endoscopy gastroenterology team is warranted in nearly all cases of acute cholangitis, even if some mild cases will not require biliary drainage. Endoscopic transpapillary biliary drainage is considered the first-line drainage procedure because it is less invasive and lower risk than other drainage techniques. Endoscopic retrograde cholangiopancreatography, or ERCP, is the procedure of choice for transpapillary biliary drainage regardless of a benign or malignant pathology. Endoscopic biliary drainage is the accepted technique. Stone extraction is done after selective biliary cannulation followed by biliary sphincterotomy. Various techniques such as balloon sweeps, mechanical lithotripsy, and electrohydraulic lithotripsy can be subsequently applied. Endoscopic biliary stenting is achieved by the placement of a stent over a guide wire into the bile duct.
These are images from an ERCP for biliary decompression. The first image is a fluoroscopic view of an endoscope with guide wire in the dilated biliary tree with large filling defects due to multiple stones prior to decompression. The second image on the right shows dilation of the biliary sphincter after a sphincterotomy.
On this slide, the first image on the left shows pus draining from the common bile duct after endoscopic decompression. The second image shows multiple large pigment stones being removed through the common bile duct after ERCP with sphincterotomy.
Percutaneous drainage is generally performed by interventional radiology and is an option for patients who could not have endoscopic biliary drainage performed successfully. Endoscopic drainage is unavailable, or if the patient is too ill to have general anesthesia for endoscopy. Ultrasound-guided transhepatic puncture of the intrahepatic bile duct is performed. A guide wire is advanced and a catheter is placed over it and into the biliary tree, allowing for drainage. Success rates range from 63% to 86%. However, there are more adverse events associated with this than endoscopic transbiliary drainage. Thus, it is not a first-line option. Rarely, when other methods of source control fail, surgical drainage is required.
As mentioned earlier, disease severity scoring may help determine timing of endoscopic management of these patients. Studies have shown that patients with moderate disease do better with early, within 24 hours of admission, endoscopic intervention. It is generally accepted that patients with severe disease requiring organ support should have emergent biliary drainage for source control once they have been hemodynamically stabilized.
In early studies, the mortality rates for patients with acute cholangitis were strikingly high, exceeding 50%. With improvements in care and advances in biliary drainage interventions, mortality rates have dropped. Recent studies show mortality of about 11% from mild to moderate disease. Although mortality rates in severe disease have also dropped, they are still relatively high at 20 to 30%.
The write-up for acute cholangitis should include an assessment of the patient and a management plan. The assessment should include the diagnostic evidence that has been obtained which favors your diagnosis of acute cholangitis. This includes evidence for systemic inflammation, evidence for cholestasis, and imaging findings which support the diagnosis. As with any assessment, a differential diagnosis should be considered. The differential diagnosis for acute cholangitis is acute cholecystitis, biliary leak, acute pancreatitis, acute hepatitis, and liver abscess. These are often easily distinguished from acute cholangitis either based on laboratory data or imaging findings. Disease severity scoring can be helpful to include in your assessment and can, again, help determine disposition and timing of endoscopic management. Your plan should include your resuscitation strategy, the disposition of the patient, what antibiotic regimen you have chosen empirically and the expected time course for the antibiotics, the patient's dietary status, i.e. NPO versus feeding, and which consultants you expect to call. Finally, the take-home points for our presentation are as follows. Acute cholangitis is an infection of the biliary tree. Diagnosis is based on evidence of systemic inflammation, cholestasis, and imaging findings of biliary obstruction. The mainstays of treatment are end organ support, IV antibiotics, and biliary decompression.
Disease severity can be mild, moderate, or severe. This scoring can help inform disposition and timing of biliary drainage. Furthermore, mortality rates are decreasing with improvements in patient care and biliary drainage techniques.
Thank you for watching our presentation. This slide shows the references we obtained our material from. Good luck on the wards.